and Dr. Talha Miran is the other academic co-chair for the Society for Heart Failure and Transplant. And our president is Dr. Jabir Abdullah Kuti sir and secretary Dr. Manoj Durairaj. And all on behalf of the entire team, we're really excited for our webinar today, which is on a slightly different topic from the kind of topics that we usually have discussions on. So I hope this is relevant and exciting for everyone. So our webinar today is on genetic testing in cardiomyopathy and heart failure. And as cardiovascular genetics rapidly transforms the way we diagnose, risk stratify, and manage cardiomyopathies, understanding when and how to use genetic testing has really become essential for clinical practice. So we're delighted to have an expert panel with us here today to help translate this evolving science into patient-centered practical care. So our first speaker for the evening is Dr. Kathirvel M. He is MD Pediatrics from JIPMER and he has done DM Medical Genetics from AIIMS Delhi. He's a consultant clinical geneticist at Apollo Main Women's and Children's Hospital in Chennai. He's a member of several eminent societies in the field of medical genetics and inborn errors of metabolism. And his areas of interest include AI in medicine, neurogenetics, oncogenetics, genome analysis, and variant interpretation. Our second speaker is Dr. Kshitija Patil. She is MD Pediatrics and DM Medical Genetics from AIIMS New Delhi and has done a fellowship in clinical genetics from KEM Mumbai as well and holds MRCPH and DCH qualifications from UK. She's a consultant clinical geneticist at Apollo Hospitals in Navi Mumbai, Nashik and Indore. And she brings with her also extensive as a clinical consultant genetics across leading genomic diagnostic laboratories, including Life Cells, Green Array Genomic Research and Solutions, and MedGenome. She's also a medical scientist at ICMR-funded National Registry for Rare and Other Genetic Disorders and an assistant professor of pediatrics at St. GS Medical College and KEM Hospitals. She is an author of multiple peer-reviewed publications in medical genetics and pediatrics and has contributed extensively to academic textbooks and has clinician education initiatives. Her areas of interest include prenatal genetics, rare diseases, genomic diagnostics, variant interpretation, pediatric genetics, and hereditary cancers. So with that, we'll get started with our first talk by Dr. Kathirvel.
Good evening, ma'am. Are my slides visible and I'm clearly audible?
Yes, yes.
Okay. Good evening, everyone. So my purpose for the next 20 minutes would be on like tracing the root from a mutation to a full-blown phenotype. So I'll be quickly going through the genetic fundamentals, assuming that most of the things, most of the basic stuffs are already known to everyone. And I will spend more substance on the talk on pathomechanism, because pathomechanism is the one which now determines the management. So this is how I have framed my talk. So under 5 objectives. So initially on the basics of genetic report and more on the compartment principle, which is the region of cardiomyocyte, which is disrupted, predicting the morphological endpoint, and per se the mechanism such as the fourth generation, transmission, adhesion signaling, energetic storage, etc. And more a little about the phenocopies, and finally more on the how the genotype alters management, such as the device threshold, targeted therapy, etc. So to start, few on the basics. So we know the central dogma. I'll be focusing more on the 4 points. So predominantly all cardiomyopathy genes are haploid sensitive, which means we get dominant pedigrees. So genes are expressed as tissue specific isoform. That's why certain variants are cardiac restricted, and protein localization determines the phenotype. This is we'll be talking about in detail. And we should also understand how the terminology moved from mutation to variant. Why? Because it's not all a change in DNA is going to be disease causing. So the mechanism of change, like how a particular change has been translated into phenotype. It's still evolving. So the new nomenclature has come up, moving from mutation to variation. So which we'll be speaking about in detail. So I just want you to understand. So this is how we currently stratify our variations. So this concept is essential to and much of cardiogenetics, something like a poison peptide, which means it is translated, incorporated into sarcomere, thereby disrupting it. Example would be our classical MIH7. Whereas in truncating variants, they undergo nonsense-mediated decay, actually producing affluent sufficiency. Typical variations such as titin, your MIBPC3, and the splice-altering variation also would have the same form, where a wrong isoform is generated at a wrong stage, thereby disrupting the downstream mechanism. And you should also understand the missense truncating, splice altering, or the point mutation. And we can also have copy number variation, where a whole gene is deleted or duplicated, thereby producing a disease mechanism. And a little bit on the mechanism of inheritance, as we know, predominantly we get dominant pedigrees, such as your cases of hypertrophic, dilated, or even arrhythmogenic disease. We get recessive pedigrees predominantly in metabolic storage disease. Consanguinity also points towards it. Rarely, we should not neglect the X-linked disease, such as Duchenne's, your Danon disease, Fabry disease, where it is also very essential not to dismiss the carrier mother, who is frequently accepted. And we also have mitochondrial inheritance, which is matrilineal, where like variability. And the major things we have to see while taking the like pedigrees is pedigree, specific inquiry into the sudden death, drowning, unexplained RTAs, any history of facing before 50, or unexplained heart failure, etc. And I would point more on these two mechanisms. One is the penetrance. So penetrance is nothing but incomplete age dependent, and its carrier status is not disease. So what I want to highlight here is the concept of penetrance we find most commonly in all cardiomyopathies, which mean a normal study earlier at adolescent age doesn't confer a lifetime clearance, which means the phenotype is evolving. It's not that alteration in gene would not translate at age-dependent time points. And the second thing what I want to highlight is we currently use ACMG 5-point classifier for characterize our variation, but it is totally database driven. It's not the full essential, like we can't label them fully under unless we carefully interpret it, which the second speaker would go more details, will be detailing more on that. So to start with my actual genetics part of cardiomyopathy, just few slides on showing the impact how cardiogenetics has changed. So we have now discovering more genes, and it is now very feasible to get genetic tests done and simultaneously screen a wide variety of genes with better accuracy and reducing the TAT. And integration is now possible. We have evidence-based guidelines, which is being published, and also recommendation for the same. And the research translation also have been more rapidly influencing our clinical decision, as well as monitoring therapy, as well as transplant decision. So just to show the highlight, as you can see, the number of genes curated for each condition, cardiogenetic conditions, as well as the diagnostic yield, have significantly come up in a long way. So previously we are using point mutation panels, whereas now we are more into doing the whole exome, whole genome, looking for candidate variation, as well as curating gene disease association. So now to move on to the actual morphological class, what I want to highlight here is, so the description here is not an endpoint, it's just a diagnosis, the overlap and temporal evaluation, like the evaluation is the rule here. So what I mean is burnt out HOCM may represent a dilated phenotype, whereas the arrhythmogenic can be more of a left dominant. So that's why it's predominantly that even the nomenclature kind of moved, even the new Padov's criteria by the task force also changed accordingly. The consequence here is that phenotype at present go in different direction. And a little about on diagnostic yield. So what is diagnostic yield? Is nothing but if you test a patient, what are the chances you're going to get positivity? So we should understand that the diagnostic yield is much higher when it is hypertrophy, predominantly dominated by the MIBPC and the MH7 load, whereas in 20 to 40 in dilated, predominantly by the truncating variation in titin, and around 40 to 60% in arrhythmogenic diseases. We also predominantly the commonest one would be the PKP2. So the major difference here is this is up to like there are like major thresholds such as the phenotypic definitions, the family history, what are the panel composition, etc., to actually contribute to the diagnostic yield. And one thing what I want to highlight is so diagnostic yield would would a relative concept, and it also depends on the assay we use. Negative assay doesn't
The
mean that
Society
it is
of
so negative. So in some cases, we just have to follow up for a new gene disease association and kind of look for candidate
Heart
genes for evaluation.
Transplant Webinar
So
Cardiac
this is the central paradigm, paradigm behind the principle of this cardiomyopathy. So the major principle here is the compartment is the one which actually predicts the phenotype. So we can make it into the 5 compartments. The sarcomere generate forces. So we use the genes such as MIH7, MIBPC3, TN, the titin related genes. So basically, the sarcomere produces sarcomere related genes produces hypertrophic and restrictive phenotypes, whereas the Z disc cytoskeleton and sarcolemmal thing they predominantly, which is transmitted through various proteins such as titin, desmin, filamin C, they produce more of a dilated phenotype, and the desmosome which mediates adhesion and also as well as the signalings such as genes related such as desmoglein, your PKP2, DSP, they predominantly produce a more of an arrhythmogenic phenotype, and the nuclear envelope and RNA handling apparatus which mediates mechanotransduction and splicing like your lamin and RBM20, they produce a DCM with early conduction disease. Finally, we also have the metabolic and lysosomal machinery, so various genes such as GAA, your GLA, tafazin, which produces more of an hypertrophic phenocopies. So the utility perspective, so the thing is when we kind of get a new report with unfamiliar gene, so the major way to go for approach would be putting into the question where which compartment the protein occupies. Thereby, you can stratify the final phenotype, the as well in this particular thing. Departments, the
Dr.
final cardiac
Kathirvel, I
phenotype
think the last minute what
decides
you spoke,
whether it's
your
gonna go into an.
voice was not
I may take
clear.
few a little more.
Sorry to interrupt. The last minute
Hello,
what
ma'am.
you spoke, the audio was not clear. Would you be able to repeat what you said in the last minute, please?
Okay, ma'am. Okay, okay.
Last two slides.
Yes, sir. Yes, sir. Yeah, so basically the central paradigm of pathomechanism in cardiomyopathy would be this organizing principle of putting into 5 compartments. So the first compartment is the sarcomere compartment which generates the force through various genes such as MIH7, MIBPC3, etc., where this predominantly any affection here would produce a hypertrophic or restrictive phenotype. The second compartment, the Z cytoskeleton and sarcolemma, which is kind of transmitted through genes such as titin, desmin, filamin C, dystrophin, etc. They eventually produce a dilated phenotype. The third compartment, which is basically the desmosomes, which mediates both adhesion as well as signaling. So these kind of genes such as desmoglein, your PKP2, etc., they produce predominantly arrhythmogenic type of disease. The other fourth compartment, such as the nuclear envelope, RNA handling apparatus, they actually mediate more of the mechanotransduction here. That's why any defect here would cause more of a dilated phenotype as well as with early conduction disease. The final thing what we have to understand is the compartment of this metabolic and lysosomal machinery. So a lot of lysosomal storage disorders as well as your metabolic pathway would have an overlap here. So these kind of any disruption in this compartment would predominantly produce an hypertrophic disease, and it will more often hypertrophic phenocopy. So the utility is more prospective here, which means one thing is whenever we get a uncommon gene in our report, it's very essential to put this protective question in which compartment these protein occupies, so that we can kind of correlate with the phenotype, the arrhythmic burden, and the surveillance we may need in case they turned out positive. So just
So your
moving
voice is
on to
breaking.
pathomechanism, how a mutated protein is actually causing the final phenotype. So I may take a few more time here. So this is the crux. So the sarcomere and the hello,
Yes, we can hear you, sir.
hello, sir. Am I audible? Yeah. So
Not audible.
I will take a little more time on the sarcomere. A short orientation. Just a second.
Sir, please check your network, sir. Sometime.
Am I audible now, sir?
Yes, sir.
Yeah. Fine. So it's very essential to understand the sarcomere and the crossbridge cycle. So we know the thick filament with beta-myosin heavy chain and the light chain, and as well as how the entire crossbridge formation happens, and the like how the entire thing would like the actual physiology happens. But I would want here to highlight more on the concept of super relaxed state. So what happens is at rest, majority of our myosin heads are merely inactive and but sequestered in a folded energy sparing formation, docked against the thick filament as thick filament backbone. The interactive head motif with ATP turnover and an order of magnitude slower than the disordered relaxed state. So the regulated reservoir of the recruitable cross bridges as and the myosin binding protein C is they actually act as a stabilizer, and the proportion of its held there would set a baseline contractility as well as that it would also determine the energistic at the diastole. So to displace that equilibrium, so you obtain either hypertrophic phenotype. If you restore it pharmacologically, you may have an or else if you try to disrupt it using a myosin inhibitor or something, the reverse would happen. So basically, both this proportion they actually follow this single structure. Hello.
Yes, go on.
Yeah. They actually highlighted a single structural concept. So when we move on to this HCM phenotype, so HCM phenotype, what's happened is the force generated within sarcomere ideally should have been exported starting from mediate as well as to the extracellular matrix and laterally to the adjacent myocyte through the intercalated disc. So this is the series circuit how it works. Whereas when we when we have any deficit in genes, predominantly the myosin related genes. So what happens here is, so the ATP energetically, as it's mentioned here, only like 2% of the 2% of daily ATP requirement is actually stored in myocardium, and the rest is synthesized in every 24 hours. So effectively, actually, there is no buffer. So that's so the inefficiency would immediately affect the diastolic dysfunction. That's the major reason mechanistically. If we take the titin Z disk or the link complex, they transduce this strain into an entire transcriptional output thereby disrupting the sensors and myocyte mistreat, leading to loading and remodeling rather than the actual without any hemodynamic stimulus. So this together actually explains why inefficient sarcomere can lead to can eventually translate to an total cardiomyopathic phenotype. So the cascades kind of runs with a different protein leading to the final phenotype. So if we take to the DCM, so when it is undilated cardiomyopathy, so here the concept here would be mechanistically enable like a failure to deliver force. So any mutation such as titin, lamin, or RBM 20 can cause the same. So here what happens is the haploinsufficiency at the level of protein, they disrupt the sarcomere assembly and also well as the impaired mechanosensing. And usually we get the dilated phenotype, the penetrance low,
Can't hear.
and
Can't hear at all.
Like the final phenotype is also kind of to the alcohol, your any drug intake or any peripartum state or any sustained state of underlying mutation as well as substrate. Hello.
Yeah, go on.
Hello. So am I audible and my screen is
Yeah,
visible?
it's better now.
Okay. Yeah.
Gone again.
So the DCM phenotype, we may need a second hit on through the existing other traditional alcohol intake and of tachyarrhythmia. Everything can actually. Sir, am I audible? The signal is
Yeah, audible
so.
intermittent.
So the other genes such as so the other genes which are described such as the lamin, your RBM 20, and also other gene which are the structural proteins such as your which are in the Z disc or cytoskeleton such as DS, FLNC, BAG3, DMD. They also form almost form a same kind of disease mechanism. So moving on to the arrhythmogenic phenotype. So here in arrhythmogenic phenotype, the major thing is like predominantly it affects the signaling. It's basically a signaling disease with structural consequence. So both can happen mechanistically, electrically, or sometimes it can be totally at the level of signaling. So mechanically, it's basically more on the desmosome pathology where it's one of the disease where when the desmosome integrity fails due to shear stress, the localization within this thin wall eye strain regions such as the right ventricular outflow tract, the subtricuspid regions, those are more affected. And this is one of the very few myocardial disease where exercise generation, exercise restriction or other physical activity restriction can actually be disease modifying rather than precautionary. So the other thing, other pathways which are implicated here is the electrical one, where the desmosome actually disrupts the connexome signal, thereby leading to conduction slowing and thereby producing electrical imbalance, leading to this arrhythmogenic state. And the third pathway where we commonly find is the signaling. So any plaque-globin which is released through this disrupted desmosome can actually suppress the WNT pathway and stimulate alterate the EPO-YAP activity. Thereby, the progenitor cells are stimulated, leading towards a state of adipogenic and fibrogenic phase. So that's the major thing which happens, leading to the fibrofatty replacement as well as the transcriptional reprogramming, which can lead to infarct modification in this particular pathology. So moving on to the final, the restrictive and non-compaction. So basically, it's almost the same gene which is having a two different presentation. So restrictive cardiomyopathy, it's rarest, and here what happens is it's more of a variant which increases the myofilament calcium sensitivity, impair the relaxation without substantial hypertrophy. So here we get the cytoskeletal group which acts through aggregation and impaired proteostasis. If in case in desmin, it would particularly we have to associate the pathology in skeletal myopathy, and conduction defect also would be more pronounced. And the other non-compaction group, currently the evidence is more towards arrested embryonic, possibly an arrested embryonic compaction. But the remodeling response and trait was we see in something like in athletes or in sickle cell disease associated cardiomyopathy. Those can also find we can also find the same kind of thing in a structurally normal heart also. Here the prognosis would also depend on actual ventricular function, the arrhythmic burden, not only the pathology. So like a possible explanation would be, as we commonly see the TNNI3 gene, which can actually exhibit a typical pleiotrophy, rather by showing the pathomechanism essentially is the shared pathway across all this network highlighted. So thereby the same gene can produce a different phenotype. So to finally, I also want to highlight more on the phenocopies. So phenocopies are very much essential, mostly in pediatric population, where totally a different pathway can lead to a different phenotype. So, and it's has to be considered while evaluating this group of patients, and a suspicion also should be raised, and treatment also is more pointed out on the actual pathophysiology rather than the compartment which is disrupted. So this slide I want to highlight the exaggerated pleiotrophy which we face while managing this condition. The major thing is one gene can produce multiple phenotype, and we have the same phenotype which is produced by different genes, and we can even see that the volume of movement outside, like as you can see, there are as you can see from HCM, we now have significant volume of movement to different disease pathology, which means we are just dealing with the phenotype whatever we deal with is just an a window to assess the particular state, but the underlying pathomechanism can be much complicated, which can in future we may have much more robust classification and much more robust phenotype. And it's also very essential to understand any common disease state can also modulate these phenocopies rather by complicating our end phenotype. So the why we have to know this mechanism, definitely because some cases like the device threshold, some mutations in lamin filament, so can increase the arrhythmic risk more than the EF prediction. So in that case, we have to go for a gene specific criteria as identified as highlighted in the ESC 2023 guidelines, as well as the exercise prescription also would determine more on the whether it is a disease modifying state, etc. And we are also now are having more targeted therapy in pipeline, such as the myosin inhibitor, transthyretin stabilizer, silencer, the small molecules, which are also can help us in getting the precision medicine up in. And the major thing is we are now kind of you not only will be using genotype only for prognostication, we may also use it for the treatment plan, as we can use the same. For example, we are moving into era where genotype specific treatments are gonna start. So that's why understanding the genotype would actually would help us in future with more like drugs with base editing, gene replacement, etc. So my final take home message would be phenotypes are just the endpoints. So the actual biology resides within the compartment, how we stratified and analyze them. So the disease mechanism may have an overlap with different kind of group of network involved, and we should always understand possible phenocopies and modification by the common disease, and the concept of penetrance should also be understood while interpreting our variation identified. So I want to end my talk with this quote by Barnwald, who actually kind of foresaw the role of genetics in cardiology. So where we may be using genetics not only for individuals, specific group of patients. So it would be the standard of care for almost the entire future of cardiovascular medicine, where integrating genetic and molecular insight would be a common part in our clinical care. So I'm extremely sorry for the interruption in the net. Sorry for the network issues. I'm happy to take any questions. Thank you so much.
Thank you so much for a wonderful talk, Dr. Kathirvel. We'll move on to the second talk by Dr. Kshitija Patil and then take questions and have a discussion towards the end.
So can I start sharing my screen?
Yes, please, ma'am.
Okay. All right. So is my screen visible and am I clearly audible?
Yes.
Okay. Thank you. Thank you for this invitation and thank you for the kind introduction. I think my colleague, Dr. Kathirvel, has taken on the difficult job of explaining the depth of this topic and explaining things in great detail. What I am going to do is discuss the role of genetic testing in cardiomyopathy and heart failure. We'll discuss this based on with some anecdotal cases so that you can see how you are integrating, maybe not really being aware, but still you are integrating genetics in your practice in cardiology. So we'll begin with I think some people are not muted. Okay, so we'll begin with the first case where a cardiac phenotype revealed a family diagnosis. Okay, so this was a 27-year-old man who presented with dyspnea on exertion and palpitations, and he had atrial fibrillation, NYHA class 2. There was a family history of hypertrophic cardiomyopathy, and a baseline echo had shown an ejection fraction of 62%. He was being followed up, and subsequently a myocardial biopsy was done, which showed this cardiomyocyte disarray and interstitial fibrosis. So if you see over a period, the progression of his disease, at 27 years, he had ejection fraction of 62%. Then he had progressive heart failure symptoms with lower limb edema. At around 32 years of age, his LVF had declined to about less than 50%, and he transitioned to end-stage HCM. By 33 years, he was NYHA class 4. And he was started on IV inotropes, and LVAD implantation was done, and he was registered for transplant. Now, looking at this hypertrophic cardio, so this is again showing his progression and the steady decline in his ejection fraction and other things. Now, if you consider hypertrophic cardiomyopathy, what is the prevalence? It is about 0.2%, which would be about 1 in 500 individuals. But this is the number of individuals who are actually diagnosed. Okay, so they are imaging defined hypertrophic cardiomyopathy, but it could actually be that number could be lower than the actual number of patients who are having a hypertrophic cardiomyopathy. Okay, many of them, they might just, get diagnosed at postmortem after a sudden cardiac death or something. So what is usually, so apparently if you have like a sporadic hypertrophic cardiomyopathy, no, so like in our patient here, there's a significant family history. But if you did not have a family history and you wanted to do a genetic testing to see what would be the yield, what are the chances that you would actually find a genetic variation. Okay, that is what we call mutation or genetic variation. So it would be about 30%. Whereas if you have a significant family history, like in our patient here, it would be the chances of getting a genetic variation would be about 60%. Now, what would indicate that we'll have a higher yield of diagnosis? If there is a positive family history, if the biopsy, like in this case, shows a classical HCM morphology, a younger age at diagnosis, there is no hypertension or any other cause explaining the LV hypertrophy, or if there is a very disproportionate great magnitude of hypertrophy. Okay, so I think Dr. Kathirvel covered these genetic aspects quite well. So basically, there are several genes, not just one. The common ones being MYH7 and MYBPC3. But definitely there are other sarcomeric genes, and we would want to test for them. And we know that if we, as Dr. Kathirvel has explained, that if we actually identify a pathogenic or a likely pathogenic variations, that is the coding error, the coding change that has been identified is satisfying enough ACMG criteria to say that it is clinically actionable. If we find something like this, we know that we have implications not just for this patient, but for his family as well. So in this case, that genetic testing was done, and and a variation was identified, genetic variation. So this is the change in the nucleotide from C to T, which has led to a change in amino acid. So this is a missense variation. And how has this genetic test helped us? That it has established that it is a sarcomeric hypertrophic cardiomyopathy, because we'll see ahead that there are certain phenocopies of of HCM as well. Okay, so now we know that if it is if a genetic cause is established, we know that it could have an adverse disease trajectory. It has implications for cascade screening, that is testing in other family members who could be at risk of having inherited that variation, and also reproductive risk, so that this variation is not passed to the next generation. Okay, so in this case, what happened was his preserved ejection fraction HCM, he deteriorated over the 5 years, and he was lined up for a transplant. Okay, now if you ask per se, the genetic variation is not going to decide about transplantation. That would obviously be decided based on his condition and his echo findings and other things. But this would just help in overall prognostication and implications for the family and also reproductive things. So now, as we are discussing family implications, look at the pedigree in this patient's case. This was the patient, 27-year-old patient. His mother had passed away because of the similar problem, and also his maternal uncle had this, and he had passed it to his son as well. Now, in this, looking at the pedigree, you can conclude that this is an autosomal dominant inheritance pattern. Why is it not X-linked? Because male is passing to male. Okay, so this can be only in autosomal dominant cases. Now, most of these hypertrophic cardiomyopathy DCM genes, they are majorly autosomal dominant. There are two important concepts that I want to clear here about penetrance and variable expressivity. So penetrance is age dependent. Now, many times what happens is, if we find a genotype positive patient, now in this case, maybe, he has 2 children. You will say, okay, let us just do echo in these patients. If the echo is normal, then we can defer genetic testing. But that is not the case. Even if you have a normal echo now, it may evolve in the future, because this penetrance is age dependent. And as the child grows, maybe at a later age, in adulthood, he may present with the disorder. So we need to know whether the genetic variation is present or not, because we need to know whether they need to be put on surveillance. Likewise, about variable expressivity, we need to understand that relatives carrying the same pathogenic variation, they can differ in age of onset, about even the magnitude, the severity of the problem, even with the same variation, there can be, because there are multiple genetic modifiers as well. So we can't be sure that the disease will be as severe. Maybe, like his mother, it was very severe. It may not be as severe in this patient, and we don't know about his children. Okay, so yeah, so these were important points. Now, as I already said, if it's what do you say, if the age of diagnosis was early, if it is a genetic proven hypertrophic cardiomyopathy, we know that usually you will find that the age of diagnosis is early. There is a greater lifetime disease burden, and there is higher incidence of atrial fibrillation, higher incidence of ventricular arrhythmias, greater risk for heart failure, and greater overall morbidity. Okay, but one limitation is that even if a genetic variation is identified, as I said, there can be population level variation. There will be patient to patient variation even with the same coding change. That is the same variation. Okay, so right. So in this case, what had happened was so what we usually normally do, you test a patient. You have to remember that a genetic diagnosis is a family diagnosis. So don't just focus on your patient. So whenever you find that, you have to test his first degree relatives, which would include his real brothers, sisters, parents, and children. Okay, and whoever are the variant positive relatives, they would have to get a baseline evaluation with echo, ECG, and periodic surveillance as per requirement. Whoever and okay, so and if variant negative ones can be at least okay, and again, I want to mention here in this first case about the reproductive implications. Nowadays, we have options of preventing the transmission of this coding error, that is the a pathogenic or likely pathogenic genetic variation, to the future generation. There are two ways of going about it. One is a natural conception followed by prenatal testing. That is, we test either by chorionic veli sampling or amniocentesis in the 3rd or the 4th month of gestation. The second way is going by pre-implantation genetic testing for monogenic disorder, that is done via IVF, where embryos are prepared outside and you test the embryos when they are at 5-cell stage, and only the ones which are not carrying the variant can be used for implantation via IVF. Okay, so there are ways of preventing the passage of this. Okay, so this was basically a case of sarcomeric cardiomyopathy. Now let us move to the second case. We'll go faster from here. So this is a case where arrhythmia and conduction disease preceded heart failure. This was a 25-year-old man with palpitations and presyncope. He presented with recurrent palpitations, and there was a strong family history where mother had died at the age of 30 with some heart failure. And multiple extended family members also had heart failure or sudden cardiac death. Now, the ECG showed changes of short PR interval, right bundle branch block, and prolonged QTC. The echo showed ejection fraction of 30% and severe global LV hypokinesia. The CT angio showed no significant coronary abnormalities, and the cardiac MRI showed dilated globally hypokinetic left ventricle. Importantly, there was no late gadolinium enhancement. Okay. Now, if you look at the trajectory of this patient, you can see that there is a very fast and a quick deterioration. At the age of 25, he had presented. At that time, ejection fraction was about 30%, and there was severe global hypokinesia. He was started on guideline-based heart failure therapy. Dual chamber ICD implantation was done for primary prevention, but the symptoms persisted. There was a lack of improvement in cardiac function despite medical therapy. Within 2 years, he was NYHA class 4, and then he was listed for heart transplant and underwent a orthotopic heart transplant. This is the explanted heart, which is showing certain changes here. It was a chronically dilated cardiomyopathy, and there was a fibrofatty replacement of the atrioventricular nodal region, and the nuclear envelope, if you see, it has undergone thinning, and there is something called as bubbling here. Okay, bubbling and convolution in the cardiomyocytes. So this is very typically seen in the LMNA cardiomyopathy, where there is electrical instability and conduction disease. So what basically happens is the LMNA gene, it is located on the long arm of chromosome 1, in the band 2,2. Okay, so this codes for two proteins, that is lamin A and lamin C. They form like a mesh on the inner side of the nuclear envelope. And this mesh, it helps in protecting the nucleus against mechanical stress. Now, myocytes are always under mechanical stress. So this lamin A and C are very important for maintaining the nuclear integrity. So if there is a coding error in the LMNA gene, these proteins will not be produced properly and there will be damage to the nucleus, the cardiac nucleus. Okay, and it can present like dilated cardiomyopathy or left ventricular non-compaction phenotype, or it can be like a sinus node dysfunction. It can present like an arrhythmogenic cardiomyopathy, atrial arrhythmias or ventricular arrhythmias, or even sometimes directly sudden cardiac death. And in most of these presentations of dilated cardiomyopathy, you will find a LMNA gene variant. So about 5 to 8% of the cases. The penetrance is high. And again, as we discussed in hypertrophic cardiomyopathy, it is age dependent and exceeds about 90% as age increases. So person carrying a variation will develop disease sometime. As he grows older, chances are higher of presenting. Okay. And what are the clues for it? Some family history of dilated cardiomyopathy, okay, or early conduction system disease, or atrial or ventricular arrhythmias which are preceding an LV dysfunction, or ventricular arrhythmias which are disproportionate to the degree of LV dysfunction. Young age of onset. Again, family history where there has been a heart transplant or a pacemaker installation or some sudden cardiac death. And sometimes they can have associated skeletal muscle disease or contracture. So typically they will have myopathy-like features, but I want to highlight that myopathy need not always be present in LMNA-related cardiac disease. Okay, so now we have a LMNA risk VTA model where you can judge whether what is the risk for ventricular tachyarrhythmia. So it depends on the gender, the left ventricular ejection fraction, ventricular tachycardias, non-sustained ventricular tachycardias, degree of AV block, and the variant type, whether it is a missense or a non-missense. Non-missense would be truncating variant, which is more severe. So with that, you can determine the estimated 5-year risk. So in this case, which I had presented, it was a male with frequent NSVTs and ejection fraction of about 30%. So this I have prepared from a case report where they have not exactly mentioned the pathogenic variation, whether it was missense or truncating variation. And again, there was right bundle branch block. So, and very significant family history. So based on all of this, a decision was taken, dual chamber ICD implantation was done for primary prevention. And so basically genetic testing helped here for cascade screening. Now we had seen in his pedigree that he is affected and he had 2 children. So he was himself 27. So by the time he got a cardiac, was designated for cardiac arrest, he was about 33 years of age, and he had a 5-year-old son and a 19-month-old daughter. His son tested positive for, so the son is genotype positive. Presently the echo was normal, but we know that he is likely. So it is a age-dependent penetrance. With time, he may develop the a DCM. While his daughter did not inherit the genotype from him, so she is safe. Okay, so in this case, again, we discussed previously, it is like a family diagnosis. At-risk children can be identified. What a genetic testing offers is, in father's case, the diagnosis occurred after symptomatic arrhythmias and with severe ventricular dysfunction, whereas because of cascade screening, we could identify his son early. Okay, so this was LMNA related cardiomyopathy that we discussed. Now moving on to third case where you have a treatable phenocopy of hypertrophic cardiomyopathy. This was a 62-year-old index patient who was diagnosed with asymptomatic hypertrophic cardiomyopathy about 20 years ago. And then he was doing fine. Then in the past 6 years, he had some chest tightness, breathlessness, some STT changes. And in recent times, in the 6 months, he had premature ventricular contractions, paroxysmal ventricular tachycardia, and NYHA class 2 symptoms. The echo at presentation showed ejection fraction of 30% and elevated tropi BNP, and peak VO2 was less than 10 ml per kg per minute. Now, ECG change. So here you are seeing the cardiac. So ECG changes were there, and as explained, and in cardiac MRI, what you are seeing is there was a diffuse LV hypertrophy with multifocal LGs in 2050. Now, when you see the follow-up here, there is LV dilatation, and apparently it looks like the hypertrophy has regressed. But actually, what has happened is it has been replaced by fibrosis, which is not really a good thing. Okay, and then this is the echo image, which is showing LV dilatation and septal hypertrophy. So if you see the progression in this case, like if you remember the first case that we discussed of hypertrophic cardiomyopathy, here you have a silent, almost kind of silent LVH, which is gradually progressing to fibrosis and then advanced failure. Like 20 years ago, he had no symptoms. Then 6 years ago, some chest tightness, breathlessness. 6 months ago, progressively arrhythmias, LVF dropping, and then finally he had advanced heart failure and his heart transplant was performed. So when should you suspect some other extra cardiac kind of, some extra non-sarcomeric, some different phenocopy of hypertrophic cardiomyopathy? When you have unexplained LVH, especially over 35 or 40 years, when it is concentric or asymmetric hypertrophy, when you have prominent papillary muscles, or when there is basal inferolateral LGE. Okay, so late gadolinium enhancement, basically it will show that there is fibrosis there. Okay, and when there is a non-native myocardial T1 and unexplained arrhythmias or conduction disease. Now, extra cardiac clues, this is very important. They very typically present with neuropathic pain and acroparesthesias. So, it's like they will say they have burning sensation in their fingers, which is very peculiar finding of Fabry disease. Then angiokeratomas is another finding, which is seen in Fabry disease, as you can see in the picture here. Corneal verticillata this is what you see on slit lamp. And renal impairment. So majorly they present with renal impairment, but in this case, patient has presented with a cardiac phenotype and no other renal symptoms or anything. Okay, so this, so in this case, if you have suspicion for a Fabry disease, like for some phenocopy and you're suspecting Fabry disease, how do you go about testing? So Fabry disease is caused because of variation in a gene called GLA, which is located on the X chromosome. Now, traditionally, Fabry disease has been told to be a X-linked recessive disorder, but we have seen female patients presenting. It could be because of skewed X inactivation or whatever. So presently, we call it like X-linked disorder rather than X-linked recessive disorder. If you have a male who is presenting with whom you are suspecting Fabry, ideally what we used to do is test for the enzyme levels. So look for the alpha galactosidase level. So basically what is happening here is because of the coding error, that is mutation, variation in the GLA gene, it is not producing an enzyme, that is this alpha galactosidase enzyme, because of which there is accumulation of the substrate lyso-Gb, and that is what is leading to this Fabry disease. So if you have a male patient, you test for the enzyme, you find that the enzyme levels are markedly low, look at the biomarkers which are raised, and then you go for the molecular testing. But nowadays, because molecular testing is very easily available, you can directly go for a genetic testing. Likewise, in females, they say because females have 2 X chromosomes, so the level of enzyme, it may not be as low to detect based on the enzyme, so directly go for a genetic testing. Now, in coming back to our patient, so in his case, the alpha galactosidase activity was low. As you can see, it is much below the reference range. Likewise, the lyso-Gl3, this is the biomarker, which is basically a substrate. So if you have low level of enzyme, there is accumulation of this substrate, and it's not getting converted into the product. So you have raised levels here, much above the reference value. Then molecular testing was done, which identified this variation. Now, this variation is basically an intronic variation. IVS is an old terminology for intron, as you know, and a gene has it will have an untranslated region, then it has basically exons, introns, exons, introns. The exons are actually the coding part. Introns are, they usually get cut out, spliced out. So basically we are usually interested in the exonic variations or the splice site variations, which are disease causing. But this is a known deep intronic variation, which is which presents specifically with late onset, predominantly cardiac Fabry phenotype. And there is a founder variation in Taiwan and parts of southern China. So this is what was identified in the patient. Okay, now why early diagnosis is important here? Because storage, this is basically like a storage disorder. If you diagnose early, so heart is one of the organs which is affected, but it has multi-system affection. So you can start on enzyme replacement therapy. There are enzyme, two types of enzyme, that is agalsidase alpha and agalsidase beta. So one of these enzyme replacement can be started, or there is also an oral chaperone therapy in form of stat.
10 मिनट खाली ज्वाइन करके हट जाएंगे बस पानी में डाल
Can everyone mute, please? I think there is some disturbance. Okay, and then standard of care obviously has to continue. The conventional cardiac management for heart failure has to continue. And timing matters because, as you saw in this case, LG, if there is extensive fibrosis, then it is difficult. Recovery is difficult. Okay, so in this case, in our index patient, what happened was he underwent an orthotopic liver transplant, and he was also started on ERT. So at 62 years of age, after the transplant, he got started on the ERT. And because of the genetic testing, we could establish the diagnosis, and other things like cascade screening and all the things that we discussed obviously apply here as well. Okay, and then these are the diagrams. I will not dwell on it in the interest of time. So this was a case of Fabry disease. Now let us look at another case where severe cardiomyopathy was there, and this is also not a sarcomeric disease. So here, a 14-year-old male presented with an oppressive chest pain, palpitations on exertion, and chronic headaches. So initial cardiac phenotype, it was a non-obstructive type of hypertrophic cardiomyopathy, and ejection fraction was 50%. The global longitudinal strain was minus 6.7%. Now, if you look at his X-ray, there is a definite enlarged heart is seen, and the ECG showed short PR interval and complete left bundle branch block. So, and this condition led to very rapid course. So initial assessment, we had seen the LVF was 50%, GLS was minus 6.7, and immediately within a couple of months, it dropped to 36. The LVF was 36%, and fibrosis also increased from 31% to about 50%. So because of the rapid, so these are the changes which we are seeing in the echo and the MRI. And echo was also showing some thrombus in the follow-up. So because of this, so when you look at this very, massive early onset ventricular hypertrophy with pre-excitation patterns and unusually short PR intervals, if there's a rapid progression from preserved ejection fraction to complete systolic dysfunction and dilatation, if there is an extensive progressive myocardial fibrosis, you should suspect something beyond the sarcomeric disease. And here it turned out to be a case of Danon disease. Usually, again, like, your LMNA types, these can also have skeletal myopathy kind of features. They can even have some cognitive features like intellectual disability. They could have retinal disease. But these extra cardiac features, if they are absent, it doesn't mean that you can exclude Danon disease. Okay, it can still be present with a pure cardiac presentation. So why it occurs? So there is this LAMP2 gene, which is basically the lysosome associated membrane protein 2. If there is a coding error, coding variation present, what it does is so the function of this gene is autophagy. Now, if autophagy is impaired, it leads to disruption of lysosome mediated cellular clearance, and again it leads to substrate accumulation and builds up intracellular glycogen and autophagic vacuoles. Now, this is not a glycogen storage disorder like Pompe. It is just it is a disorder of impaired autophagy. Okay, this leads to hypertrophic and fibrosis, and that leads to oxidative stress, myocyte death, and severe architectural remodeling, and that leads to very severe, very quick course of disorder. In this case, a genetic variation was identified. Now, if you see here, there has been a deletion of a few nucleotides. And how many, if you count, 645 to 651 is 7 nucleotides. So it is, as you know, the codons are in multiples of 3. So three nucleotides will form a codon. So this is not a multiple of 3. So you know it is going to lead to a frame shift. So it will shift the reading frame. And these mutations are usually truncating and deleterious mutations. This was a likely pathogenic variation and a hemizygous. So this gene is located on the X chromosome. This patient was hemizygous. His mother was found to be heterozygous for this variation. Now, if you see, initially he had presented with this severe hypertrophy and symptomatic presentation. He deteriorated quickly. ICD implantation was done. It was a refractory disease and he required transplant in less than 2 years at about 15 years of age. Okay, 15 and a half years of age. So this is the explanted heart where the myocardium was tested. It showed these, if you see these blue arrows, this is the stored glycogen, and the black arrows, they show the vacuoles. Okay, in the cytoplasm. This is a very typical image showing confirming a Danon disease. Now, how it has helped here is that it has clarified that, okay, this is the underlying cause, because as you know, these genetic causes, they will have extra cardiac manifestation and will require treatment accordingly. Again, cascade screening and the other things as discussed. Okay, so this was a case of Danon disease. Now, quickly, I will discuss 2 more cases. One is of mitochondrial cardiomyopathies. In that, I want to discuss 2 different types. One is MELAS and one is Barth, because MELAS is basically related to the mitochondrial genome, whereas Barth syndrome is related to the nuclear genome. Okay, so usually when we think of mitochondrial myopathy, so they can present with hypertrophic cardiomyopathy or dilated cardiomyopathy, left ventricular non-compaction, conduction abnormalities, arrhythmias, or advanced heart failure. Okay, but they need not always be, mitochondrial doesn't always mean the mitochondrial genome. There are more nuclear genes which determine the, which are causative of the mitochondrial disorders than the actual mitochondrial genes. Okay, so let us look at case 5A and 5B. 5A was a case where it was a pathogenic variation in the mitochondrial DNA. So usually the most of our genes are inside the nucleus, that is the nuclear DNA. But this one is lying outside the nucleus in the cytoplasm. Okay, and this gene MTTL1 M.3243A2G. This is a very known common mutation causing MELAS. Okay, it follows maternal inheritance because, as you know, the cytoplasm comes from the ova. So this is only maternal transmission. And heteroplasmy means what percentage of the mitochondria are carrying this coding error, carrying this mutation. Okay, now that differs from tissue to tissue, as Kathirvel very nicely pointed out in his talk, that it depends on the tissue. Like you can test from the blood, but in the blood the heteroplasmy may be 50%. In actual cardiac myocytes, it may be 80%. You don't know. You will know only when you test the cardiac myocytes. Okay, so so that is MELAS. Likewise, Barth syndrome is something different. We'll see when we come to it. In the case of MELAS, what happened is, was a 30-year-old man who was a known case of MELAS. He presented with WPW syndrome, LV apical mural thrombus. There was embolic events and progressive advancing heart failure. The pre-transplant ejection fraction was barely 5 to 10%. He also had extra cardiac involvement. So usually in case of mitochondrial disorders, because of the multi-system involvement, overall poor prognosis, usually they are discouraged from transplant because, you know, you don't know what would be the prognosis and how it will affect the other systems. So in this case, there was also intellectual disability, short stature, sensorineural hearing loss, skeletal myopathies, and advanced chronic heart disease. In this case, initially cardiomyopathy panel was done, but nothing was diagnosed. Some VUS variant was diagnosed, which was not matching the phenotype. So then phenotype was reassessed. He was indeed having stroke-like episodes, hearing loss, short stature, and with all of this, they suspected that it could be MELAS. And so a trioexome and so they just tested everything, all the exome plus the nuclear genes plus the mitochondrial genome was tested. In that, they came across this variant, where if you see here, it is 53% heteroplasmy in the peripheral blood. Okay, and mother is also carrying this variation. But his actual cardiomyocytes, his brain, all different organs will carry different percentage of heteroplasmy. Okay, so this is what this diagram is depicting basically. Okay, in the interest of time, I will just move forward. So in this case, pre-transplantation, he was started on all the supportive care, CoQ10 was started, OPD basis milrinone was given as a bridge, and all multidisciplinary assessment was done. And very importantly, when you know that it is a inborn error of metabolism, you need to take other care, like you have to prevent catabolism, you have to prevent hypoglycemia. So all that other additional management for preventing stroke-like episodes, IV arginine is given, and all these things were done with due care. Heart transplantation was done, and within 15 hours, kidney transplantation was also done. And post-transplant ejection fraction was 60 to 65%. Okay, so some initial donor-specific antibody, some episode occurred, but after that he was clinically stable at the last follow-up after 15 months. Okay, and you can see the change in the echo, like from a ejection fraction of 5 to 10%, it's now 60 to 65%. Now let us look at another case of where a male infant with cardiomyopathy, growth failure, and neutropenia. Now here prenatally, there was a fetal growth restriction and placental insufficiency. The prenatally, there was right ventricular myocardial thickening was detected in the antenatal ultrasound. Male baby was born at 36 weeks, 2.4 kgs. Neonatal period, there was some bradycardia, hypotonia noted, ejection on echo, ejection fraction was 55%. He was started on medical therapy and but kept having recurrent admissions for heart failure and sepsis. And then in childhood, he was more or less okay up to 3 years of age. But later, but because of his repeated presentation, his genetic testing was done, which revealed a hemizygous TAS gene variation. Now look at this variation. Here also there is a deletion, but if you see how many nucleotides are deleted from 525 to 533, so there are 9 nucleotides deleted, which is a multiple of 3. So it is not so it is not changing the reading frame. It is not a frame shift, but a in-frame deletion. So this but again, this variation is a likely pathogenic variation. It was inherited from the mother who was heterozygous. But remember, this is a nuclear gene. Okay, nuclear gene causing a mitochondrial condition. Now, systemic clues here, skeletal myopathy was there, growth delay was there, intermittent and persistent neutropenia was also present, and there were recurrent infection and 3-methylglutaconic aciduria seen on the TMS. So this is the chromatogram showing the mutation which is identified in the proband, and mother was a carrier for it. So mother will obviously be heterozygous, whereas the child was hemizygous for it. Okay, and in this case, if you see, the heart size was very large. He was managed with initially, he had an LVAD implantation, ultimately underwent a transplant, and then later he was doing well. This is basically just, summarizing both the cases that I discussed in detail. This was a case of amyloidosis, but I think in the interest of time, I'm just going to quickly go through it. Saying this was a 65-year-old Korean woman who did not really have heart failure symptoms, but had a significant history of 2 out of 7 siblings dying because of heart condition. And her brother was detected with the ATTR amyloidosis. Okay, so, and then when she was evaluated, she had a cardiomegaly. And on echo, there was a concentric LV thickening, and a very peculiar finding there where you suspect amyloidosis is when you have an echo which is showing a thick wall, but a ECG showing low voltage. Okay, so that is why this was suspected. So as you know, there is AL and then there is ATTR. You want to rule out AL first. So for that, serum urine electrophoresis and immunofixation was done. There was no monoclonal gammopathy, and serum free kappa lambda ratio was normal. So now, cardiac technetium 99 scan was done, endomyocardial biopsy was done, and immunohistochemistry was positive for transthyretin, and Congo red staining was positive. Genetic testing was done, and it identified the variation, and it was same as that in her older brother. So now basically we know that it is in amyloidosis, what happens is there is a protein misfolding, and this is a autosomal dominant disorder, and the 50% chance of passing to the next generation. It is very important to diagnose it in time, because the treatment window, opportunity window, will go down as the patient progresses to advanced cardiomyopathy. And as we saw in this patient, they may not present with overt symptoms in the beginning. So in this patient, the tafamidis was started. There is a disease modifying strategy was started, but her heart failure was progressing, so she underwent a transplant, and she was actually doing well. Now, the controversy here is that usually amyloidosis, we know if it is a genetic condition, the amyloid deposits will occur again in the transplanted heart. So whether it is worth transplanting them, but we have studies which have shown that patients with amyloidosis, when transplanted, actually do well, and the survival at 1 year is 100%, 92% at 3 years, about 90% at 5 years. So even the older age group patients who underwent transplant did well on it. Okay, so and again, as I said, genetic testing helps us to know what is the recurrence, whether they need to be on surveillance, and also cascade screening and other interventions. And you also have the disease modifying agents which need to be added. So I think all these things have been discussed quite well, and I would be happy to take any questions if maybe I will, should I?
Hi, Dr. Kshitija and Dr. Kathirvel, thank you so much for, may I ask? This is Dr. Archana Sate from Pune. I
Yes.
happen to be a
Hello.
pediatrician with a special interest in genetics. So,
Oh.
yeah, thank you for your very, very immersive, elaborate discussion on all these cases. I need to know a little on the patient, the 14, 15-year-old, where you've used COQ10 and L-arginine, I think?
Yes, yes, yes.
Yes. So just can you give little more information on what your logical use for it and the results and how long?
Okay. So this let me just clarify, this was not my patient. I had taken this patient because I was trying to focus on cases where genetic disorders received a cardiac transplantation. So this is a case report. I can share the paper here. So basically, it was a patient who underwent. So usually, mitochondrial disorders. At least in our setup, we usually hesitate to transplant them because there are so many other comorbidities, and it is a multi-system involvement. You transplant the heart, but then the kidneys are affected, the liver is affected, etc. In this case, it was a case of MELA. So it has a proper management guideline. So as in case of any inborn error of metabolism, we need to ensure that they don't that their diet is maintained properly. We have certain so depending on which disorder it is, they have certain management. So it's not like a mitochondrial cocktail, as we say, but coenzyme Q. Then there are certain micronutrients, supplements are advisable, and IV arginine has a role in case of stroke-like episodes.
Stroke prevention, you said. Yes.
Stroke prevention, yes.
So there is hope for, certain disorders where you can actually give a chemical treatment available is possibly a happy thing to say, right?
Yes, ma'am. Absolutely, ma'am. And so very importantly, like in this case, he underwent combined a heart and a renal
And kidney
transplant.
after
Yes.
15 days, you said.
Yes.
And just one more question, please, if you're allowed. The IUGR baby who was picked up, you said, had an RV echo abnormality, right? In
Yes,
utero.
yes.
Yeah.
Yes.
What was that? What was the abnormality? I missed. There was a voice.
Okay, so
There was an RV, right ventricular abnormality picked up on that little baby who was at 3 years of age finally diagnosed to have the mitochondrial
yeah. So
neutropenia, the one with
so shall I
neutropenia.
So it was just a right ventricular myocardial thickening that was
Thickening.
should I
But-
share? Yeah.
Thickening. Okay.
Yeah. And then the baby was delivered, like they did not intervene at that point, and then it was evaluated at birth, and then he just kept having, he was just started on routine like anti-failure medical measures, but he kept like having decompensations and repeated admissions. So then they kind of
That's quite
investigated further.
intriguing because, to assess the RV and the LV, because they're more or less the similar sizes, of course, there is thinning that is expected to happen in the RV as the baby is getting older, which did not happen. Understood. Thank you. Thank you.
Thank you. Thank you so much, Dr. Kathirvel, Dr. Kshitija, for very engaging discussions. There are a couple of questions in the chat. I'll just read them out, and out of either of the speakers can jump in with the answers, please.
Sure.
So someone has asked, an adult patient with HCM is coming. What genetic tests and where would you send? What about family screening?
Right. So I would say usually we always say in genetics that phenotype is the king. So whatever additional information, so HCM you got on the echo, are there any additional features as I showed in my slides? You get is there, do you see angiokeratomas? Does he have any other complaints? Does he have acroparesthesias? Does he have any other manifestation? Is there a significant family history? I would encourage drawing of a pedigree. I mean, of course, it's difficult in busy OPDs maybe, but I mean, you should definitely try to get this additional information. And whenever there is a suspicion, like with each case, as I had discussed, whenever you have certain red flags, like a significant family history or some additional extra cardiac manifestations, and you're suspecting a genetic disorder, particularly here as the question is for HCM, I would say there are panels as well as there are broader testings available. I think Dr. Kathirvel covered it very nicely. So usually panels will cover certain genes. The advantage of sending a panel, usually they say that, okay, there is a more depth and those, because the amount of data generated is the same. So if you're focusing only on some genes and not all the 20,000 genes, maybe you will get more depth in the variants, but we are not expecting low depth variants here. So it is okay. And I would suggest, I mean, if I may say broadly, it is better always to send for an exome study. But when you are sending for a broad test like an exome, always give maximum possible phenotypic information as you can. Like, any skin stigmata, any additional findings that you can provide to the laboratory, because variant filtration is a very tough job, and the more information we have, the better we'll be able to give you an output. So I would say exome sequencing is a good thing. And family screening, what about family screening? So family screening cascade screening should occur only when we identify a pathogenic or likely pathogenic variant in the proband. So always test proband first. And after the proband, depending, if you get a VUS variant, uncertain significance, you have to rework the patient. You have to see how much of the phenotype is matching, take help of your geneticist colleagues, ensure and make sure whether you want to, because 90% of the VUSs ultimately will reclassify as benign or likely benign, and only 10% will go to pathogenic. So only when you have identified a pathogenic or likely pathogenic, you can go for cascade screening. Otherwise, you cannot offer. You have to just do monitoring based on maybe your ecos and.
Thank you so much for that. And I'll just ask an add-on question to that. When you have a VUS, what is the role of parental testing in that situation?
Okay, so there is one of the,
if the VUS fits the phenotype.
Okay, so see, VUS fitting so there could be so many coding. So you check one patient's data, compare it with a standard. So currently we are comparing it to GRCH 38. You compare it, you will find 20,000 to 50,000 coding changes. Okay, and most of them will be benign, but we are searching for some. So now HCM, now there is MYH7. There will be so many codings. How to, and you will just say, okay, there is hypertrophic, so phenotype is matching, right? You need more than that. So there are certain things like we have a lot of databases that we refer to see whether this variation is present in normal population, whether it is present in patient population, whether it has, we have to actually, it is hard work where you have to go back, look at PubMed search and do all those things, because there are so many criteria other than the segregation criteria. Okay, one way in which it can help, as we have seen, most of these are autosomal dominant disorders. And if we test the parents and find that, okay, it has not come from either parents, and or we can say, okay, it is de novo, more likely that it is a confirmed de novo, it can add one of the ACMG criteria and maybe push it towards pathogenic or likely pathogenic or pathogenic. But if one of the parents is actually carrying the variation, okay, and you do an echo and you say that, okay, echo is normal, so parent is carrying that mutation, parent's echo is normal, so we can disregard this variant. I can't say it so easily, because as we have seen, the penetrance is age dependent, and the same, you can say, okay, but his child has got the HCM at such young age, maybe parent has not manifested till now, means he is normal. No, they can present at late age also. Because there is variable expression in patients, there are so many disease modifiers present, like epigenetic mechanisms, etc. Okay, so you cannot rule it. So if you are suspecting like autosomal dominant disorder, if parents are not carrying it, it is one thing which can push towards, but you have to see ultimately what all criteria. Did it satisfy PM2? Is it rare in nature? Did it satisfy PP3? Is it a truncating variant? Is it satisfying PVS1? So it is not necessary that a parental segregation will definitely push it to likely pathogenic, but it may add certain criteria which may push it. So we have to see it as a whole. But yes, segregation is useful.
Thank you. Thank you so much for that. I think in the interest of time, we'll just take two last questions, and maybe Dr. Kathirvel, if you could answer this question, is what is the indication for genetic testing in patients with dilated cardiomyopathy?
Ma'am, the thing is, we per se it will boil down to the question of what is the threshold we use, because there are certain art points where we consider going for the test, like the typical DCM with family history and early onset of the disease, or a typical echocardiac signature, those kind of things. But in the current era, the testing has now become very mandatory, and it has been exercised by cardiologists more for ruling out a disease, and also with existing undifferentiated phenotypes are also very well tested with that. So the thing is, we currently don't have a specified a strong criteria on choosing the choosing our patients accordingly. But there are certain cases where the testing would be upfront, but in the testing option should also be considered even in normal cases. So that's how it's going to evolve. And a routine evaluation with genetic tests may be mandatory in the future also, with upcoming new much cheaper affordability of this test, and for a newer interpretations. I hope I could clarify your questions. Can you could be more specific on the type of the patient profile that can help me in answering this better?
Definitely. So now, actually, according to the ACC guidelines, it is a class 2 in A indication in select patients with non-ischemic cardiomyopathy to refer for genetic counseling and genetic testing. It is a class 1 is to at least do a family at least to do a family history, at least 2-3 generations, to see if there is any family history. And if you have a family history, then there is a stronger indication for genetic testing. And then I think we'll just take one last question, which is, can these patients post-transplant, if they have a genetic cardiomyopathy, can they develop cardiomyopathy in the transplanted heart, particularly if there is a lysosomal disorder?
So, are you asking for the transplanted patient or?
Yes, any patient post-transplant, like Dr. Kshitija, some of the cases that you mentioned, can the genetic cardiomyopathy recur in the transplanted heart, particularly if it is a lysosomal disorder?
Actually, the thing, ma'am, for example, it totally would boil down to the actual pathomechanism. For example, if it is a Fabry disease, so unless the transplanted tissue, which is the heart, the enzyme content would be fine. So, there won't be any severe affection of the transplanted organ, but the generalized pathology would remain, and the patient, despite being transplanted, can have the secondary complications, which means the enzyme deficient in other tissues can keep the pathophysiology running. The transplanted tissue would be fine, but it would sustain definitely the secondary complication due to the systemic deficiency. So other than that, in other genetic, currently there are even transplant boards which prefer genetic screening of the donor, just to avoid any heterozygous or carrier states, or any significant findings, just to oversee this transplant compatibility. But in overall, the tissue survival would depend on multiple factors. But however, the transplant tissue retaining the normal enzyme level, the progression would not, dysfunction would not be immediate, but the secondary complication would be expected there.
Thank you so much for that. I think.
Can I ask a quick question?
Yes, ma'am.
Thank you very much. I'm Swati Garekar, pediatric cardiologist, addressed to either of you. I have a toddler who has a Titin gene positive mutation. DCM is there. That's how she presented. And The DCM EF has improved from 10% to now 40%. The parents want to know what to expect in the future. Titan mutation positive, clinically doing well, and ejection fraction improved.
Kathirvel, are you going to take that? Okay.
Ma'am, more on the type of mutation, please. Like exact mutation and other.
I'm sorry, all I remember right now, it's Titan gene positive. So are you saying that more details
So
of that?
actually, so madam, Titan gene, it is a very, very large gene. And it is like notorious among us geneticists in throwing up a lot of variations. Many of them are VUS, benign, I've seen very few pathogenic or likely pathogenic mutations or variations in the Titan gene. In fact, in most data, you will find some or the other VUS in that gene. So unless there is actually, so you need to see when you look at the report, the genetic report, there is it is summarized in a table which is given. So beside that Titan gene, they will have mentioned the C dot change and the P dot change. Beyond that, they will have mentioned the classification, the ACMG classification. Have they classified it as pathogenic or likely pathogenic, or is it VUS? I would say if it is a VUS.
Yeah, it said pathogenic, yes.
It said pathogenic, right? I would say, and whether it is pathogenic or likely pathogenic. Because if it is a likely pathogenic with a PVS1, PM2, because many laboratories, so this also depends on what laboratory you send the testing to. Some of them do not apply the ACMG criteria very stringently. Sometimes, because especially with PVS1, which is a very strong criteria, which directly pushes the variation to likely pathogenic with a PM2. And a lot of those variations, you will actually not have features, but the variant is classified as likely pathogenic, and then you are confused whether it is actually causative of the disease or not. I would say a good idea in this case would be to segregate this variation in the parents. Titan gene has several, allelic disorders. Some of them are dilated cardiomyopathy, some are some other things also. So just see whether it is autosomal dominant or recessive, how it is segregating in the parents. Try to see how, if parents are carrying it, then look at the echos of the parent and see whether it's actually fitting the phenotype. So I think a reverse phenotyping is important in this case.
Certainly, I'll do that. And I suppose nobody knows whether she'll sing again or not.
But I think a good reverse phenotyping and studying the variation can help, and maybe some PubMed search regarding that particular variation, what patients are there, and what has been the trajectory of the patients who have been reported with that variation.
Got it. Thank you very much.
Thank you so much to both the speakers for amazing, incredible, very insightful talks and a very interesting discussion afterwards as well. I know a lot of people probably have other questions. The slides will be available and the talks will be recorded and available on YouTube. And we can share the email addresses of the speakers as well if you would like to reach out to them for questions later on. So with that, we'll end. Thank you so much to all the speakers and all the participants for attending.
Thank you for this opportunity. Thanks a lot.
Thank you, Dr. Kshitija. Thank you, Dr. Patil.
Thank
Have
you,
a good
Dr.
one.